is in Chapter 18, Cardiac Emergencies. So we'll talk about acute coronary syndromes, including cardiac arrests. Talk about what to do if you find a patient in cardiac arrest, how to use an AED, and or our big fancy manual defibrillator, the Zoll. We'll talk about things you need to worry about with AEDs, not too much. And briefly, mechanical CPR devices, so like an auto pulse. Okay, so just a refresher on the anatomy and physiology. 4-chambered heart, blood comes in from the body through that vena cava, superior and inferior. Gets kind of staged there in your atria, right? And then pumped into the ventricles, and then up and out through the lungs, and then back into the left atrium, into the left ventricle, out to the body, right? So tonight we're going to add the cardiac conduction system and how that all works to this thing. So go ahead, let's get the whiteboards going here. You guys are going to so this is the non-Mickey Mouse version of that. If you guys want to go back to wherever you were sitting, that's fine too. Hot? So again, SA node, AV node, or atrioventricular, sinoatrial, and then those little pathways. Okay, I think we've seen this exact slide before, but when blood is getting out to the body, when it's coming from the heart through your arteries, out to the capillary bed, returning through the valve, through the veins that have valves in them. Okay, so let's start talking about what can go wrong here. So acute coronary syndromes are basically lumping all together issues that happen where the heart's not getting enough oxygen. So there's lots of different things that we'll talk about under this general heading of acute coronary syndromes. Some of these signs and symptoms are similar to non-cardiac conditions. So just try and rule out cardiac things. Things like stomach discomfort and pain, like that feeling of indigestion, can be either a heart attack or it can just be indigestion. So if you're treating somebody that's just got signs and symptoms of indigestion, think heart maybe. So chest pain is the best known symptom. It's usually a dull or crushing, heavy or squeezing kind of feeling. Sometimes people will just describe as being, extra tired, even not, able to do as much as they could do. Maybe just a vague discomfort. When it's a more significant pain, it can radiate usually to your left side. Sometimes it radiates up through jaw. occasionally abdomen. Basically, we're not used to feeling pain from our heart. There's nerve endings there, and you can feel pain, but our brains aren't trained on it like you're trained to feel pain anywhere else, on fingers or toes or whatever, right? So most people aren't able to localize it terribly well or describe it terribly well. Breathing difficulty can also be a sign symptom. In some patients, that might be the only complaint. It's just breathing difficulty. This is especially common in diabetics and women, actually. Other signs, symptoms they might be complaining of: anxiety, feeling of impending doom, nausea, like upset stomach or indigestion, sweating, either slow or fast pulse, tachycardia or bradycardia. Abnormal blood pressure is either high or low. So when you're doing your assessment, you do your standard primary assessments, check your ABCs, start them on oxygen if appropriate. For people complaining of chest pain or chest issues, OPQRST is pretty much ideal. They're complaining of some kind of pain, right? So. Get your sample history, vitals. Put them in a position of comfort. Most of the time, this is going to be best to leave these people sitting up. Most of the time. If you've got somebody that's having like runs of tachycardias or their heart's going real fast, they might prefer to lay down. So somebody with low blood pressure. But just as common, you're going to find them with really high blood pressure. And those folks, you're worried about lungs being full of a little bit of fluid, so those folks you want to keep sitting up. Give them oxygen. And with these, the oxygen we're going to titrate to effect. So you don't want them super saturated with oxygen. You don't want to have them sitting there at 100% O2 and you're, or 100% on the pulse ox and you're just blowing more and more oxygen at them. And then transport. The sooner these folks, if they're having a heart attack, the sooner they get to a cardiac cath lab, the better off they are. So the expression here is time is muscle. When somebody's having a real heart attack, their cells in their heart are dying. So the sooner you can get those coronary vessels dilated and opened back up, the less heart muscle is going to die and the better prognosis they're going to have. So in Idaho here, as part of this is the Idaho optional module signal symbol for EMTs, you're going to do a 12 lead ECG, which these little Zoll things will do. Yeah.
I just wondered, does Gritman have a cath lab?
Lewiston is the closest cardiac cath lab, yeah.
So if we were to have a heart attack patient, would we take them to Gritman and Gritman would find a way to transport them there?
They'll stabilize and then, and go down, usually.
Oh, okay.
Yeah.
Would they fly them?
Occasionally they'd fly, yeah.
Because it's a 20-minute drive.
Yeah, that makes it a little shorter if you're in an ambulance, but you'd save a little time with a helicopter. It's just not, you wouldn't save a ton of time with a helicopter. And so we can go through the 12 lead ECG thing here tonight. I'll show you that. Basically, what a 12 lead ECG will do for you is take a bunch of different looks at the heart. So I drew kind of a nice idealized PQRST pattern there. And you can see it kind of looks like this one, which is kind of our typical lead we look at. But a 12 lead looks from a bunch of different directions, basically. And using all those different views of the heart, you can hone in and tell pretty specifically where they're having a heart attack, or if they're having a heart attack at all. And this thing's got a fancy enough computer in it, it does all the analysis for you. You just hook it up right and it spits out a nice little thing. I think the patient's having this kind of heart attack. So that's pretty cool. Any guesses as to which one is the best or the most important drug to give a patient? Oxygen. You gonna vote for anything different?
Is it aspirin?
It is aspirin, actually. As far as a single drug that'll improve like the overall patient outcome, as far as them being released with the fewest amount of deficits, aspirin actually is the one. Reduces the clotting factor a little bit, makes your platelets a little more slippery. Yeah.
But they have to chew it though, they can't just like swallow it.
Right. And dispatchers actually will generally, they have instructions to have people that are having what appear to be cardiac, related chest pain. They'll have them chew aspirin even before the ambulance gets there to get it on board. Oxygen you definitely should administer, but it's not going to make as much difference. All the other ones are things you really shouldn't administer to somebody having a heart attack. Nitroglycerin, so this is the other thing that you can give in the field. So indications here are chest pain. They'll have a history of cardiac problems. That's why they'll have a prescription for nitroglycerin. And in some places, it'd be online medical direction before you give it. Our specific protocols don't say that you have to call before giving nitro. So the most common way you'll find it is in either little pills or in a spray. Not an inhaler, but an actual little spray. So contraindications, again, if their systolic blood pressure is less than 90 to 100, you don't want to give it because it lowers their blood pressure. And if they've taken any kind of erectile dysfunction drugs, then you don't want to give it. With the erectile dysfunction drugs, you have to specifically ask them about those. So you can't just ask them what their medications are and assume that if they don't say Viagra or Cialis or something that they're not taking it. Because people are kind of hesitant to volunteer that kind of information. So you need to very specifically ask, have you taken any erectile dysfunction type drugs in the past 48 to 72 hours? So the Viagra's are the more immediate acting ones. You probably get away with like 24 hours, but the daily ones.
I know that day to day people on blood thinners aren't supposed to take like aspirin, ibuprofen drugs. Is that irrelevant in the case of heart attack?
It's a relative contraindication, so it's not an absolute one. That would be one where you might go ahead and call for medical direction and give them a little history and see whether they want you to give it or not. But yeah, that is a consideration for aspirin. Sure. And then for aspirin here, indications: chest pain. They gotta be awake enough to chew and swallow these things. And depending on local policy, authorized. And then contraindications. So if they can't swallow, if they're passed out or whatever, or just altered mental consciousness, or altered level of consciousness such that they can't follow directions, then you can't give them aspirin. If they've got allergies to it, obviously you don't want to give them that. The history of asthma, why that's a contraindication, but that would be probably another one where I would call. And then other anti-clotting medications. This is your Coumadin, warfarin, which is the same thing, heparin, those kind of drugs are anti-clotting medications. And again, that's going to be a relative contraindication that you might want to call the ER doc on, or at least ask while you're giving them a report or something. So a lot of times it's better to risk a little bit of interaction with that anti-clotting medication than not. So yeah.
I think the history of asthma would be on there because isn't there like a correlation between people who have asthma and an allergy to aspirin? Like a lot of times.
Something like that, yeah. And again, this one is a relative contraindication. Okay, so which drugs are we gonna give this guy? Oxygen. Yes, no? Yeah? He's at 95, which isn't terrible, but we can get him up a little higher. So I'd first start him on a cannula anyway, yeah. Okay. Nitroglycerin? No, his blood pressure is too low. If you give him nitro, he'd probably pass out and maybe go bad. So don't give him nitro. How about aspirin?
Yeah.
Yeah. At least given what you know there, he's not.
What's the definition of the genia pectoris again?
So we haven't actually talked about it. So angina is where you start having chest pain with exertion. So it's kind of like a partial narrowing or partial blockage of those coronary arteries. But it is relieved with rest. So if you go out and shovel your walk or something, you might come in with a little chest pain. But if you sit there and rest a little while, it goes away. That's angina. Yeah, we'll talk about that here coming up. Okay, so causes of cardiac conditions. So basically you can lump these things into two major categories. Your electrical dysfunction-y things and your mechanical problems. This little was say so. At some level, it's all due to some coronary artery being blocked up, right? And where it is in the heart that's blocked up leads you to one or both of these kind of problems. So long-term coronary artery disease kind of happens as we age, especially if the more sedentary lifestyle, without a great diet, you're going to end up with fatty deposits in your arteries. Your arteries get narrower and narrower. And if something else comes along, some little embolus can block them off. Basically, you get a thrombus that forms, just kind of a little bit of a blood clot that's not completely blocking off a vein. A little piece of that thing breaks loose. If it doesn't dissolve itself, then you can keep traveling through vessels until it gets to a small vessel and blocks it. And this doesn't only happen in the heart, obviously. It can be wherever. So we talked about pulmonary emboli, pulmonary embolus. That's where it gets stuck in your lungs. If it gets stuck in a little coronary artery, then you have a heart attack. If it gets stuck in a little vessel in your brain, you have a stroke. So if it happens to get stuck in one of your coronary arteries, then that part of the heart isn't going to get perfused. And if your heart muscle doesn't get perfused, doesn't get oxygen and glucose and all the other things it needs, it starts to die. The other thing that can more rarely happen is an aneurysm.
Is this under coronary artery disease, or is it like a whole new section?
It can be under that subheading, but aneurysms don't only happen in your heart. The ones that we're the most worried about is your AAA, an abdominal aortic aneurysm. But when aneurysms happen in your brain, then that's another way a stroke can occur.
So it'd be like a brain bleed, pretty much. Okay.
And again, this isn't quite as common, but it does happen occasionally. electrical malfunctions of the heart. Some of these are the result of inadequate blood flow to either your SA node or AV node, anywhere in that septal area of your heart. If those parts get lack of blood, you can have various weird electrical malfunctions. Some of these things just happen due to exterior stimuli, so this idea of cardiocommotous, that's the word. If you just get whacked in the chest really hard by something like a baseball, say if you're the pitcher up there on the baseball mound, or on the pitcher's mound, and get a baseball hit right back at you right in the chest. Some people have gone into fibrillations that way. If it happens at the right time in that PQRST cycle, specifically if it happens right on the T as your heart's repolarizing, and it can send it into a fibrillation. I'll see if I can find a decent video of like a karate tournament. The guy gets just kicked in the chest, whack, and he just falls over dead, basically, because of that thing. Send it into fibrillation. The mechanical malfunctions of the heart, the angina thing that I talked about, your AMI or your heart attack, and then CHF, which is kind of the chronic outcome of other heart problems. So we'll go through each one of these. So angina here, this is chest pain when there's insufficient blood flow because there's some narrowed artery there. But you usually only get the pain when you're working harder than normal. So if you're sitting watching TV or just doing normal day-to-day stuff, you wouldn't normally have chest pain, but do a little extra exertion and then you get chest pain. And again, the way you can tell it's angina and not a heart attack is just because pain goes away when you take it easy again, when you rest. Versus an MI or a myocardial infarction. So this is death of some part of the muscle in the heart due to lack of perfusion, lack of oxygen. So that's what infarct means, is death of that tissue. And this is typically because those arteries have narrowed over the years, and you get a little embolus in there. And then CHF is kind of the more long-term outcome of other more acute heart problems. So this is not where a part of the heart tissue is dying or anything. This is just something has happened to the heart at some point, maybe gradually over time, but it doesn't function as efficiently as it should. So, diseased heart valves, hypertension, some kind of obstructive pulmonary disease, or you had a heart attack. some time ago. And your heart doesn't work as well because a little part of it is dead now, essentially. So, typical progression of CHF, you have a heart attack, AMI, some part of that left ventricle dies. Because of that damage, you get pulmonary circulation issues. If that's not treated longer term, you end up with other parts of the heart trying to compensate and then failing eventually. So signs, symptoms of CHF, tachycardias, breathing difficulty and cyanosis, bluish skin. Typically an elevated blood pressure, normal to elevated. Diaphoresis and pulmonary edema. And again, these are the patients that you really don't want to lay down. Other signs, symptoms, anxiety and confusion because they're not getting enough oxygen. Edemas, especially pedal edemas. You'll get the people with big swollen feet and ankles. The jugular veins can be swollen. Enlarged liver and spleen is not something you can really see in the field, but I'm just going to sum it all up. Pedal edema, rapid heart rate, shortness of breath, whitish lung sounds, pale, cool, clammy skin, maybe cyanosis. Breathing difficulty because they've got fluid in their lungs. Okay. Questions on any of that? Okay, cardiac arrest. So this is the AHA's chain of survival, the American Heart Association, AHA. So to give people the best chance of surviving cardiac arrest, these are the things that need to happen. One, somebody's got to be around to figure it out and activate EMS. So if you go into cardiac arrest and nobody's there, you're kind of SOL. Then you need early CPR. And typically, if you want to have a decent chance of surviving it out of the hospital, that's got to be bystander CPR, not a first responder CPR. First responders are usually just too slow to get there. Then rapid defibrillation. And ideally, that again is coming from something closer than a first responder, but as long as you can get CPR going early enough, a first responder, like in Moscow, all the police vehicles have AEDs on them, and their response time is usually about 2 minutes to any kind of given scene. So that they'll get there and put their AED on and defibrillate if necessary. Then you need effective advanced life support. So advanced life support usually means paramedics. Sorry, you have a question?
Yeah, like, how would, cause like people are like, organ donors and stuff too, like, I know like with that, like the tissues dying and stuff, when they're having a heart attack, so do you still, like, if there is CPR going on, like, do you guys do like a lot of, saving of the organs, I guess, or like, how does that whole process work?
You certainly could. I mean, it's worth checking the driver's license to see if they're an organ donor listed on their driver's license. A lot of them will have it written on the back. But basically, yeah, you keep doing CPR and transport, and just call early to the hospital and tell them that it's an organ donor. Generally, if there's any chance that the person's going to be saved, we're going to be transporting anyway, right? So I guess the difference would be keep doing CPR on somebody that you otherwise wouldn't, maybe.
Okay.
But yeah, does that answer your question?
Yep.
Yeah, so advanced life support, for us that means paramedics getting out there. And typically a paramedic in most places can do essentially what the ER would do, just out there in the field. They're going to follow the exact same protocols. So all of this has been pre-standardized, so from the AHA. So we'll do our BLS provider class as soon as I get the new materials in for that. That BLS provider class is the same class that doctors and nurses take. And then the next level up, the ACLS class, Advanced Cardiac Life Support, that class is standardized across doctors, nurses, and paramedics. And so when we get our paramedics out there in the field, they're doing the same protocols, same exact thing that would happen in the ER, just out there quicker instead of having to transport to the ER. So that's a good thing. Then after you get a pulse back, hopefully, then they need some fairly specialized aftercare, post-resuscitative cardiac arrest care to have a good prognosis. Again, if you're out there and you go into cardiac arrest on your own, you're not likely to survive that one. So to get CPR started earlier, the best way is to have more lay people out there trained, so that if somebody goes into cardiac arrest, there's hopefully somebody close by. Dispatchers will instruct people to do CPR, but if they haven't had training, sometimes they're fairly reluctant. Sometimes it's just a mechanics thing, and the 80-year-old woman doesn't want to or can't manipulate her 80-year-old husband to the floor and do CPR on him. Sometimes it's just age-related issues that people can't do CPR. And rapid defib, again, we have defib units in all the police vehicles. We're going to have medics available pretty much 100% of the time, but just in case not, I mean, there are times when we just have one medic running around, and they do go out on medic rendezvous and stuff out in the county, so it's not inconceivable that you could find yourself doing CPR without a paramedic. In that case, you're going to want to do your CPR a little bit on scene and then rapid transport, get them to the ER. And then all of the integrated post-cardiac arrest care is all basically the job of the ER and hospital staff beyond that. So eventually probably ending up in some kind of cardiac cath lab to try and fix whatever it was, whatever vessel that got blocked off. So this is all stuff that's going to happen in the ER. Although the 12-lead ECGs, not for cardiac arrest patients, but we can do those things in the field for patients complaining of chest pain. Okay, so your role in this whole process is going to be CPR and defibrillation, possibly. So these are, I don't know, kind of our most involved calls. There's a lot of stuff going on. May I have a guess which one of these things is the most efficient at getting a pulse back in somebody?
B or D.
I'm hesitant to answer because I want to say B because of the chain of survival, but I also feel like the A, like early defibrillation with the AED would be the most effective of spontaneous return.
Well, it says spontaneous circulation. I would guess defib also.
Yeah, so it is defib. So CPR itself is just keeping things alive until you get to defib. So if the defib never shows up, the odds that the CPR is going to get a pulse back for you is pretty low. Very, very low. It's not impossible, but it's pretty low. So the earlier the defib gets there, the better. So again, if you don't get defib before 8 minutes, it's really lousy survival. I got there's the survival curve there. So even if the defib arrives in 5 minutes, you're still looking at 30% survival. And that's pretty fast, getting it there. So our typical ambulance response time is going to be closer here to the 10-minute mark. When you start having people drive from home and then get the ambulance and then get out there. And so if we were relying on the ambulance to bring a defib, you're in the 10% survival rate. When we're working with 2 minutes to defib arrival, we've got a decent chance. So types of AEDs, most everything now is a semi-automatic defib. In fact, I've never seen a fully automatic defib out there. And most everything is biphasic these days. It's the new standard. It's just more effective. So all of these things, including this one, have some little computer in there, a little circuit that reads the rhythm and decides what to shock and what not to shock. So your role is just to hook the thing up quickly, and it will decide whether they have a rhythm that's shockable or not. When you get up to paramedic level training, then you can read the little rhythm on the machine yourself and decide whether to do a manual defibrillation or not. But anything less than a paramedic, and you're relying on the computer to do the analyzation for you. So these are our older Zols. I don't think we have anything left around anymore. For a while we were keeping one as a spare. And then that's our new guy there, the Zol X series. So when it's gonna shock, or one of these two rhythms. This is what they look like on the screen. So VTAC, which again is one of those ventricular foci, when some cell in your ventricle is just going tick, tick, tick real fast. Again, this can be a pulsatile rhythm as it's organized enough, and the heart is still sitting there, perhaps doing its thing. Just remember that what you're seeing is representative of the electrical activity of the heart here, not necessarily the mechanical activity of the heart. So it might be sitting there doing this, and it looks like it's beating along, but the heart's actually just maybe very, very little, actually contracting with each one of these electrical depolarizations, right? So that's why it's going to shock this, regardless of whether there's a pulse with it or not. And then VFib, again, is when a bunch of those little cells are just all trying to get the pacemaker at once, and it's just sitting there going nuts. It's not organized at all, and this never has a pulse. So what the AED is doing is it's defibrillating, right? So it is coming in, and when that thing fires, it's basically saying, shut up, and it just turns everything in the heart off. That's what it's doing. It's not jump starting the heart like you see in most movies, people being flatlined, and they'll be like, clear, you bring him back, he's flatlined. Flatline is not a shockable rhythm. If you shock somebody in asystole, they're just like double asystole. They're extra flatline. It doesn't start the heart, it creates asystole. That's what your defibrillator does. They'll go from one of these crazy rhythms to flatline. And the idea is that one of these other pacemakers takes over again, because fastest pacemaker wins, right? And if one of these things is going, then the normal pacemakers can't work. It's actually kind of shocking how many movies and TV shows all get that wrong, but yeah.
In the book it shows like non-shockable rhythms or pulseless electrical activity in asystole. What about like bradycardia?
Yeah, that wouldn't be shockable either.
That would be, okay.
Yeah. Bradycardias are paceable. If you have a medic on scene, they might try and pace a bradycardia.
What is that?
So pacing is basically where you hook up the defib pads, and then you use the defib pads as an external pacemaker. So you're just like repeatedly shocking their heart and saying beat, 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 and it's not comfortable for the patient, but it's usable when their heart's going way slow, and they're like if they're having a heart attack where it takes out kind of the whole septal area there, and none of the normal pacemakers are working, then yeah, pacing can be what keeps them alive.
Okay.
Yeah.
So would that be like what a pacemaker, like a artificial pacemaker would be? Would it be for like bradycardia type stuff?
Yeah, typically, yeah.
It'd be pretty much replacing the SA and the AV node because they no longer work.
Yep.
Okay. So you wouldn't want a pacemaker put in if you had like chronic ventricle tachycardia.
There isn't anybody walking around in chronic VTAC. In AFib, you can have people that are running around in AFib, at least in nursing homes and stuff. That's not all that uncommon. And what that looks like is you'll have a QRS and T wave, but you won't have any P waves. You'll just have a little jittery line, which is the atria just fluttering along. And then every once in a while you get a QRS and then a T coming out of it. But it's the hallmark of AFib is it's irregular. So like this is a nice regular rhythm. It's wide and it's kind of ugly looking, but it's regular. AFib will be like beat, 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 you know, really regular.
So AFib is a whole bunch of the those.
It's normal looking QRS complexes like that, but there's no P waves.
Gotcha. And it's all the little ones fired at the same time, and then the ventricular is just one of them taking over.
And it's just that only every once in a while one of those little AFib things gets through the barrier between the ventricles and the atria and causes the ventricles to depolarize. That's what it kind of looks like. It's a real fuzzy little baseline, and you'll get a QRS and a T, and then not very well, another QRS and a T, and maybe a little longer QRS and a T, you know. So you've always got this little underlying weird little fuzziness, and maybe it'll be a real long time, you know, that kind of thing. Just really regular. And you can't always tell the difference between just road noise, basically, and that lower AFib. But yeah. Things to watch out for AEDs. If you like just pull a patient out of a pool or something and they're super wet, it might not work very well. Because water conducts electricity, and you don't want the water on their body to conduct the electricity around them. Similarly, if they're lying on big metal something, just be sure that nobody else really is touching that big metal something. So, most likely thing I can think of is like metal stairs or something. You can certainly use your AED in cars and vehicles and stuff, and that's not going to cause issue. It's not going to cause issue on the gurney. You want to make sure nobody's touching the patient or the gurney, really. But medicine patches, like nitroglycerin patches, you want to remove those.
Because there's that little needle inside of the patch or something? Or?
No, there's needles in those things. It's just, it can get in the way of where you're putting the pads, usually.
Oh, okay.
So this is like a little medicine patch. If you're touching the patient when that thing is defibrillating, then there's a real risk of you getting some carryover shock and it, you know, messing with your heart rhythm. So make sure that everybody that's doing patient care around that patient doing CPR gets themselves clear. So if you're the one that's going to push the button, make sure that you're saying clear out loud and looking and making sure that nobody's touching before you push the little zappy button. So typically, again, the ambulance is not going to be the first responder on scene. So it's going to be police, most likely, probably a fire command officer, probably a paramedic, probably an engine crew. The first fire department person there should come in and check a pulse and make sure that we're actually doing CPR on somebody that needs CPR. Lay rescuers especially are not particularly good at checking pulses. In fact, the American Heart Association doesn't teach lay rescuers to take pulses anymore at all. So, yeah. Put your AED on if it's not already, if there's not already pads on them. The most likely circumstance around here is the police will have been there first, and they'll have their AED and its pads hooked up. On purpose, they're all the same brand AED as this machine, So you can just unplug their pads from their AED and plug this thing into their pads. So you don't need to rip off the AED pads that are already on the patient.
Are the pads as spendy as the machine in retrospect? Like,
No, the pad, well, so we have a couple of sets of like fancy pads. Pediatric ones, there's some adult ones. Last time I remember they're $25, something like that, for a standard set of pads. I'm guessing these ones, these are extra fancy pads. They have a little puck in them. I can actually pass this around here if you want to look. They have a little device that goes right in the middle of the chest where you push on the chest that gives you feedback as to how well you're doing CPR. So it measures like depth and rate, and it can basically tell you whether you're doing good CPR or not as good CPR. Basically all AEDs work more or less the same. You turn them on, you hook up the pads, and then you do what it tells you to do. It's for a standard AED. It'll just talk to you and say, shock advised, clear, press the flashy shock button, resume CPR. And that's where these things are a little different. These don't talk to you. They will give you some written instructions on the screen, but they don't talk to you. They have the option to, but we have turned that off for several years now. So the thing that's going to help people survive the best is doing essentially continuous CPR as much as you can and having no interruptions as much as possible in CPR. If you hook it up and it does its little analyze thing and there's no shockable rhythm, then the thing will say no shock advised, and you just keep going doing your CPR. So Wesley was saying the rhythms that it's not going to shock are PEA and asystole. So those are the other common rhythms that you'll find somebody in out there. So PEA is when you have some kind of rhythm on the monitor. It might look like that, it might look like that, and there's just no pulse with it. So the electrical bits of the heart can be working and putting out a little bit of signal that you can read, but mechanically nothing may be happening. The heart may not actually be beating with each of those. And then again, asystole or a flat line is a non-shockable rhythm. I'm pretty sure the new ACLS guidelines don't want you to pace that either. It's not a paceable rhythm really either. It used to be a paceable rhythm, but
why wouldn't they want you to?
just because it's not, outcomes aren't high. Let's put it that way. Like the survival rate is essentially nothing when you're pacing asystole. Yes, you might be able to pace that heart a little bit and get some kind of reaction out of it, but it's not going to lead to a surviving patient.
Good.
And again, as much as you can, we're going to do consistent, constant CPR with as few interruptions as possible. That becomes pretty tricky when we got to move somebody out of a house. And so it's no longer than 10 seconds, and that's the very longest you want to interrupt compressions. And then again, given the fact that sometimes you got to get somebody out of the house, and if if you're carrying somebody down the stairs, it's pretty hard to do compressions when you're carrying somebody down the stairs. And some of these guidelines are a touch out of date here. So compression should be 2 to 2.4 inches for an adult. And the rate is now 100 to 120. It's not a minimum, it's 100 to 120 per minute. So there is such a thing as too fast compressions. Any given person can only do decent, effective compressions for a few minutes. And so you need to rotate people through
How deep
to
is
keep
the new?
quality.
How deep is the not 2? It's
2 to 2.4 for an adult. So it's not at least 2, it's 2 to 2.4. So every 5 years or so, these things get revised slightly. There haven't been any major changes for a while, but 10 or 15 years ago, they went and changed stuff up quite a bit. But the last couple updates have been pretty minor updates in comparison. If you get a pulse back, they might begin to wake or move. I haven't actually seen anybody wake up. If you start getting skin tone, color improving, that kind of thing, check a pulse, see if you've got a pulse. Maybe you can stop doing CPR for a little bit. It's not uncommon to do CPR for a while, get a pulse back, just breathe for them a while, lose the pulse, do CPR some more, get them to the hospital, maybe they lose the pulse. CPR and all this external stuff is not fixing what's wrong with the patient. You're not correcting that blocked vessel in there, right? So. So if you manage to get the pulse back, manage the airway, it's pretty common for you to get a pulse and then not be breathing spontaneously still. So you want to manage the airway pretty carefully, make sure not to hyperventilate. You might think, well, a little oxygen is good and a lot of oxygen is better. If you start hyperventilating somebody, the other thing you're doing is you're blowing off excess CO2, which changes the pH of their blood. When you start changing the pH of the blood, you start changing how the cardiac conduction system works, and you start making it more sensitive, and you start making it more prone to arrhythmias. So you gotta ventilate at the appropriate rates. So that's 1 every 5 to 6 seconds, or 10 to 12 minutes. Again, it's fairly common to get a pulse back and then lose it again. So keep the defibrillator on, keep it ready to go. Hypothermia protocols. So I haven't heard much about hypothermia stuff in a few years. But this was going to be the next thing for a while there. It's not in our protocols at the moment, but basically for post-cardiac arrest care, there were some studies that were showing better survival rates if you made the patient be hypothermic down to like 92 degrees or something like that. And basically kept him down fairly hypothermic for a while and then kind of brought him back up out of it slowly. There was some research saying that led to better outcomes. But again, I haven't heard much about it recently, so they might have expanded that research and decided maybe it wasn't worth doing. If you're transporting and they do go back into cardiac arrest, you don't necessarily need to stop the vehicle, especially if you have a medic on board. If you don't have a medic on board and are relying on the AED to monitor the rhythms, just pay attention to how much artifact you're getting as you're bumping down the road. You're probably still okay to keep going with modern machines. You're better off getting them to the hospital. The danger here of using these things in a moving vehicle is that basically little bumps and jolts from the road can get interpreted by this thing as signal, as heart signal, and mess up what it's trying to read. If you've got the pads on with good contact, the risk of that is fairly low. We'll hook somebody up to the cardiac monitor itself, and you can see that any kind of shakes or bumps or anything do wind up on the machine. But again, with the computer reading through the defib pads, it's less of an issue. Okay, so whip out your whiteboards again. Do this exercise. What's that?
Oh, it's Russian. Alright, boss man. 1 through 5. Uno. Rose. Drei. Vier. Fünf. Yeah, 6 in
From
German.
arrival or like?
Sechs.
Yeah, basically when you get on scene, what are you gonna do based on what the patient is doing for you? So you get on scene
For like cardiac.
for like a cardiac arrest.
So we're on scene.
You're arriving on scene for a cardiac arrest.
Cool.
Yeah.